Today we're going to be watching a video from Dr. Aaron Boster. He's very intelligent, especially when it comes to multiple sclerosis. So let's go ahead and jump into it and play the video.
Howdy! Thanks for learning about MS with me, Aaron Boster. In this video, let's dive into an understanding of multiple sclerosis, a chronic condition affecting the central nervous system, that's brain and spinal cord. By the end of this video, you're going to understand what MS is, what causes it, what kind of symptoms it creates, and importantly, how to treat it. Now don't turn away, because all of that starts right now.
Subscribe to this guy because he knows a lot.
Myelin, the protective sheath around nerve fibers, helps neurons send electrical impulses quickly and efficiently. The myelin sheath is oftentimes compared to the plastic coating on the outside of an electrical wire. Now, when the covering is damaged by MS, it exposes the wire and blocks the signal being transmitted. Multiple sclerosis is an autoimmune condition where the immune system mistakenly attacks and destroys the myelin, interrupting signals sent between neurons in the brain and spinal cord. This damage causes scars in the brain and spinal cord. That's actually where the term multiple sclerosis gets its name. Sclerosis means scars. And where those scars occur determines what kind of deficits the person may have. We can see difficulties in multiple neurological domains, such as sensory, motor, cognitive, bowel bladder, amongst others. Multiple different immune cells are involved in the autoimmune process of multiple sclerosis. One of them, microglia, are resident immune cells, meaning they live inside the brain. Under normal circumstances, they help the neurons by cleaning up debris and keeping the oligodendrocytes healthy. Unfortunately, in the setting of MS, they become overly active, and they literally start to eat things they're not supposed to, like your brain. The brain is protected by the blood-brain barrier, which is a selective filter that keeps out harmful substances that would harm the brain. However, in the setting of MS, autoreactive naughty B and T cells leave the bloodstream and enter into the brain where they can cause inflammation, damaging the brain and spinal cord. Key takeaway: myelin is vital for fast and efficient nerve communication. And in the setting of the autoimmune process of MS, damage to the myelin leads to symptoms that we'll discuss in the next section. Now, whereas the exact cause of multiple sclerosis remains somewhat unknown, we do understand that it involves a genetic predisposition and then environmental risk factors. Research has recently clarified that exposure to Epstein-Barr virus, or EBV virus, is probably required to later develop multiple sclerosis. Other environmental factors increase a given person's risk to develop MS. Things like exposure to smoke, obesity, and low levels of vitamin D. Question: did you know that EBV could be a trigger for MS? Leave your answer in the comments section below. There are several classifications of multiple sclerosis, each with distinct patterns of progression. Number 1, radiologically isolated syndrome, or RIS. This is when MRI findings of the brain and spinal cord are highly consistent with MS in an individual.
They found a pinpoint lesion in my brain, and that's how they knew that I had MS, along with the spinal tap that they gave me. But let's go ahead.
Individual who has been completely asymptomatic, had no clinical symptoms. RIS may indicate a higher risk for that person to develop MS later in life. Number 2, clinically isolated syndrome, or CIS. This is a single episode of neurological symptoms lasting at least 24 hours, caused by inflammation or demyelination. CIS may or may not go on to develop into multiple sclerosis. Number 3, relapsing multiple sclerosis.
That's what I have.
This is the most common form of MS, characterized by relapses, attacks, flares, exacerbation. That's all the same thing. That's when an individual has a focal bout of neurological dysfunction, which then may fully or partially recover. Number 4, secondary progressive MS. Initially presents as relapsing MS when someone has clinical relapses. Later in the disease course, they stop having relapses or have them less often, and they will accrue disability independent from relapses. And number 5, primary progressive multiple sclerosis, which is marked by a steady decline in neurological function and accrual of neurological symptoms from the very start, without relapses. Key takeaway: there are several different classifications of multiple sclerosis, each with a distinct pattern of progression. Symptoms of MS can vary based on the location of the plaques in the central nervous system. Common MS symptoms can include, number 1, motor symptoms. These can be things like muscle weakness, tremors of the limbs, difficulty with coordination, or spasms, cramps, and Charlie horses. Number 2, sensory disturbances. Things like numbness and tingling, or various types of pain, like Lermit's phenomenon, when you bend your neck down and have electrical signals shooting down your back into your feet. Or the MS hug, the only hug you don't want,
Never
where you
had
feel
that.
like your waist is being squeezed like in a vice. 3 is visual symptoms. Things like optic.
When I explained my story in the last video, that really affected me before I got diagnosed. That was a symptom that came on really quick. I thought I was going blind. I didn't know what was going on, but now it totally makes sense.
Neuritis, when swelling of the optic nerve causes loss of vision in one eye and pain when you move your eyeball. Or double vision, when you see two of objects. Number 4 are problems with the up theres, thinking and memory, energy, and mood. For example, difficulties with anxiety and depression. And number 5, problems with the down theres, bowel, bladder, and bedroom difficulties. Key takeaway: multiple sclerosis can cause a wide array of neurological problems, including motor, sensory, vision, cognitive, emotional, bowel bladder, and sexual deficits. Diagnosing multiple sclerosis.
Before we go on, I just want to let you know that I also have gastroparesis. I don't know how it came on. I don't know how it started. I don't know if it's MS related or if it's related to when they cut my stomach open and fix the perforated ulcer that I have. So I do have problems going to the bathroom, and I think that's a part of the gastroparesis. I just have to let you know that.
Sclerosis is quite complex, but its core is to look for what's called dissemination in space and time, meaning you identify neurological deficits localized to brain and spinal cord that occur in different locations at different points in time. There are 5 elements to an MS diagnosis if we use patient-friendly language: the clinical history, the examination, the MRI findings, spinal fluid, and hey, prove it's nothing else.
Exactly.
Let's talk about each one briefly. Number 1 is the clinical history, which is basically the patient's story. We call that the clinical history because it sounds highfalutin. We're listening for the presence of MS clinical attacks, or the subacute onset of neurological deficits localizing to the brain and spinal cord. Or we're listening for the slow, insidious progression of neurological deficits as seen in primary progressive MS. Number 2 is the neurological examination, where we test the various neurological systems. Sometimes I jokingly call that the MS Olympics. On the neurological examination, we're looking for exam findings that buttress the clinical story. Number 3 is the MRI scans. Typically, an MRI of the brain, cervical, and thoracic spinal cord is obtained. Here, we're looking for classic lesions or white spots in specific locations. These include periventricular, juxtacortical or cortical, optic nerve, the base of the brain called the infratentorium, or spots along the spinal cord. These have a classic appearance which is highly suggestive of multiple sclerosis. Number 4 is spinal fluid. We do a lumbar puncture and collect spinal fluid, and on the same day we collect blood, and we compare the antibody response or the immune response in both compartments. In 90% of people impacted by MS, they have an elevated immune response in the central compartment, in the spinal fluid, which is manifested as the presence of unpaired oligoclonal bands, or OCBs, or an elevated IgG index. And number 5 is, hey Aaron, prove it's nothing else. We need to exclude entities that could mimic multiple sclerosis. These are things like metabolic conditions, infections, and other autoimmune conditions, to name a few. Key takeaway: an early and accurate MS diagnosis is crucial for effective disease management. Worsening on neurological examination can occur from 2 different processes in MS: relapse-associated worsening, or RAW, or progression independent from relapse activity, or PIRA. Let's talk about both. Relapse-associated worsening, or RAW, occurs with incomplete recovery from an MS attack. So if we use the example of an optic neuritis, where inflammation of the optic nerve results in blindness, and then it recovers only part way, and that person is left with, let's say, 20/200 vision. They're now legally blind, but they can see some. They've accrued disability because of raw, relapse-associated worsening. The second way that people impacted by MS can develop worsening is from PIRA, progression independent from relapse activity. In this scenario, someone develops difficulties in neurological function completely separate from having an MS attack. PIRA is often attributed to underlying neurodegenerative processes. It can be seen in anyone with MS, even in early relapsing MS, although it's more commonly seen in secondary progressive and in primary progressive forms of multiple sclerosis. Key takeaway: monitoring of both relapse-associated worsening, RAW, and progression independent from relapse activity, PIRA, is essential for comprehensive MS care. The prognosis for people impacted by MS can vary based on the type of MS, symptom severity, and response to treatments. Several factors can influence the prognosis for a given individual. As it relates to demographics, being of male sex, being of a non-Caucasian ethnicity, and presentation of MS after the age of 40, morbid obesity, exposure to smoke, either smoking or secondhand smoke, and low levels of vitamin D are all independent risk factors for a more aggressive disease process. Certain clinical factors also increase the risk for a worse prognosis. These can include incomplete recovery from attacks, a multifocal presentation with initial attack, meaning more than one neurological system affected at the same time, frequent attacks in the first 2 years, and attacks that involve the motor system, coordination, or sphincter involvement, meaning the down theres. Certain MRI and laboratory features can also increase a given person's concern for more aggressive disease. Having a high burden of spots at the initial diagnosis on brain is concerning. Having lesions in the base of the brain, called the infratentorium, and having spinal cord lesions also increases the risk for more aggressive disease. Likewise, having enhancing lesions early on in diagnosis, or having new spots that show up early on during serial MRIs are concerning. The presence of unpaired oligoclonal bands on CSF or an elevated neurofilament light chain in the serum are poor prognostic factors. Now, whereas MS is not considered a fatal disease, untreated, it's the leading cause of neurological disability amongst young people. With the earliest application of the most effective disease-modifying therapies and aggressive attention to symptomatic management, however, we can expect an excellent life quality and a normal life expectancy. Key takeaways: advances in MS treatments and care have greatly improved long-term outcomes. There's currently no cure for multiple sclerosis, but let's be honest, there's no cure for most conditions in medicine. We don't, for example, cure high blood pressure, we treat it. And as I make this video in the beginning of 2025, today we can make MS boring. We accomplish that goal through treatment of relapses, disease-modifying therapy, and symptomatic management. Let's talk about each one in turn. When someone suffers an MS relapse, we can hasten recovery by using high-dose corticosteroids. This can be given intravenously or orally. For severe attacks that don't respond to steroids, we can use other treatments, such as total plasma exchange or plasmapheresis, or IVIG. Disease-modifying therapies have revolutionized MS care. The earliest application of the most effective disease-modifying therapies have dramatically changed MS outcomes. The goals of these therapies are to stop relapses, to prevent new spots on the MRI, and to...
Right now I'm taking Tecfidera, and I've been taking it for 4 years, and it's supposed to, like, not, it's supposed to stop the progression, I guess you would say, of the MS, and not so you don't have relapses. And I think it's working pretty good for me. I tried Rebif, and that wasn't for me. Tried a couple others, and it wasn't for me. It just gave me bad side effects and everything. But the only side effect from Tecfidera is you kind of turn red and you get real itchy. It's like a sunburn, but it goes away in about 10 minutes. But I'd rather have that than the side effects that I had from the other medications. So that's why I stick with it.
To slow disability progression. Symptomatic therapies help improve quality of life. If we slow your disease down and you're miserable because of symptoms, we're not
Told you
doing our
to
best
slow it
job.
down.
And we can improve your quality of life by treating symptoms, such as improving the up there's, working on energy, mood, thinking, and memory, or improving the down there's, helping control bowel, bladder, and bedroom difficulties. Treating symptoms is a key element to improving quality of life with MS. Likewise, lifestyle modifications is a key element to living your best life despite having MS. This includes not smoking, which can speed up MS.
If you liked the video, give me a thumbs up and give me a subscribe. I have no subscribers, so help me out. This is JT. Have a blessed day.